My name is Dr. Maher Al-Shar. I'm the Co-Medical Director of Bariatric Surgery at St. Luke's University. We are very pleased and honored that you have decided to join us for this info seminar. St. Luke's University Weight Loss Center is one of the busiest and most successful weight loss centers in the region. We have performed more than 2,000 cases. Our cases are done laparoscopically and include bypass surgeries, gastric sleeve gastrectomies, and also banding. In addition to that, we do a very high number of revisions for patients that already had weight loss procedures at other places. Our results are amazing. We are very proud of our patients. Our program also includes many support staff like dietitians and social workers whose job is to make that process and that journey easy and enjoyable as well. So again, thank you so much for joining us. Please enjoy the information seminar that we are about to present. And now I would like to introduce my partner, Dr. Leonardo Claros.
Hello, my name is Leonardo Claros, and I'm the Program Director as well as the Bariatric Section Chief for St. Luke's Health Network. Welcome to our info seminar. We are extremely proud of our program. We have performed over 2,000 cases and we have incredible results. Our numbers, complications, and outcomes are among the best in the whole country, and we certainly have the numbers to prove it. So we are really glad that you are considering surgery with us. Both myself and Dr. Al-Shar have been formally trained in bariatric fellowships, which means that we have dedicated extra time of our training just to learn this specialty, and this is all we do. We are both board certified, and our center is a designated center of excellence by the ASMBS and the ACS, two of the most respected and accredited surgeries in the world. Thank you for joining us, and I hope you like our info seminar. Well, once again, thank you for joining us, and let's talk about obesity. If you are interested in bariatric surgery and you have been considering for a while or just a short period of time, know that you're not alone. In the past 20 years, adult obesity has doubled in this country. As a matter of fact, 3 out of 5 Americans are either overweight or obese. And this has a huge impact in the health of the patients. This is causing about 300,000 plus premature deaths annually, and this is on the rise. Even more sadly is that 75% of obese children become morbidly obese adults. This is why we need to impact on their health right now. Sadly, the United States leads as the most overweight and obese nation in the world, with about 67% of the population within this category. As you can see in the slide depicted there, the numbers are on the rise in countries like Australia, Russia, the UK, but it's nearly as close as with the problem that we are currently facing in the United States. For many years, it was thought that obesity was the result of the lack of will, lack of interest for exercising, and people just not eating the right things and frankly just being lazy, and that is not true. We know that that is largely unscientific, it's counterproductive, and that kind of thinking and reasoning is what got us where we are today. We know for a fact that obesity is a result of multiple factors: physiological, environmental, behavioral. Think about that food is an addiction, and there's a very strong genetic predisposition for patients to become obese. So it's not as simple as to say, oh, you just need to eat better and exercise more. It is a myriad of factors that actually contribute to an individual to turn into an obese person. Why should you lose weight? As I have said before, obesity has a very, very high implication within your health. Obesity is associated with multiple medical conditions. We're going to call them comorbidities, and we're going to talk a little bit about them in a minute. The risk of early death that is associated with obesity is double compared to non-obese individuals. And the risk of death from diabetes or a heart attack is 5 to 7 times greater. Obesity is a known risk factor for diabetes, heart disease, stroke, high blood pressure, arthritis, sleep apnea, high cholesterol, heartburn, gallbladder disease, depression, asthma, and many cancers. There are like about 71 conditions associated with obesity and the metabolic syndrome. We just listed the most common here. We also know that many cancers have a direct correlation with obesity. Some of these cancers are esophagus, stomach, colon, liver, gallbladder, pancreas, in males, kidney and prostate, and females, breast, uterus, cervix, and ovarian cancer, just to name a few. Unfortunately, about 80% of the obese patients that we have and come to our center have at least one of these conditions with them. It is not uncommon to see that some of them will have all of the conditions on the left side in the left column, and some of them are even cancer survivors or were recently diagnosed with cancers. So obesity on itself, it's a disease, as it was clearly stated by the American Medical Association not so long ago. Unfortunately, obesity has a higher death rate from cancer in males, and it's even higher for females, about 62% compared to the 52% observed in males. The risk of diabetes is about 70% just due to excess weight or obesity in the United States alone. 70% of that diabetes risk comes from obesity. So let's talk about your BMI. This is an acronym that stands for Body Mass Index, and this is a ratio. It's a number that comes from dividing your height over your weight, and it's expressed in kilograms over meter squared. You don't have to do the formula. You don't have to calculate it on your own. A bunch of applications on the smartphones, or you can Google it. And the importance of this is that you're going to be able to find out what is your BMI. And that is going to allow us to determine the degree of obesity that you have. By definition, a BMI is normal when it lies between the range of 18.5 and 25. That person is considered overweight if the BMI is between 25 and 29.9. Obesity, by definition, is when an individual has a BMI of 30 to 35. Severe obesity is 35 to 40 with an associated condition. And morbid obesity, just by BMI alone, is an individual with a number of 40 or greater. The importance of determining your BMI lies in that we will know if you qualify for surgery or not. If your BMI is between 35 and 39.9 and you have an associated medical condition like the ones we were talking before, obstructive sleep apnea, diabetes, hypertension, or something else, then you do qualify for surgery. On the other hand, if your BMI is 40 or greater, just by number alone, you qualify for the operation. Now, this is very important because you could be interested in having a procedure, you could have diabetes, you could have sleep apnea, but if your BMI is 32 or 33, then you do not qualify for surgery. Your insurance will not pay for it. On the other hand, if you haven't been seen by your primary care physician within the last 5 or 10 years, and your BMI is between 35 and 39.9, but you do not have a documented condition, then insurance is not going to pay for that either. Don't worry about it. Just determine your BMI. Come to the info seminar. Come to our office. We will help you determine this. What are the options for weight loss other than surgery? Over the last decades, there has been a lot of emphasis on exercising, dieting, and medications. Many diets, more diets than the terms in the Webster Dictionary, really. The Atkins diet, the Zone, the Hollywood, carbohydrate sparing, the pomegranate, the cabbage diet. You probably tried them all. Do they work? Not really in the long term. Most of them will be successful in the short term. You might be able to lose 20, 25, 30 pounds. Some people are successful losing 50 pounds or so. The problem is that as soon as you stop those diets, you pack all the weight and more. And the problem is that we were not designed to subsist in that kind of diet. No one is going to be able to live in a cabbage diet for the rest of their lives. And that's why these things are not effective in the long term. A lot of medications were tried in the past, and unfortunately I have to tell you that nothing else works. There's no magic pill out there that just by taking it you're going to melt or burn fat and you're not going to be obese anymore. That just doesn't happen. Now, I am not saying that exercising, dieting, and taking the medications that you're prescribed is not good. I am saying that once you have reached a BMI within the range that the ones that we have talked before, exercising, dieting, and medication is not going to be enough. It's not going to work. You have a 95% chance of failing at doing these 3 things on your own. Where surgery, depending on the operation that you choose, is about 80% successful at containing your weight and actually making you healthy. Now take a look at this. This is about the surgical option, and I'm going to read it for you. Only surgery has proven effective over the long term for most patients with clinically severe obesity. You would say, well, this is probably something that we invented. Surgeons like to operate, would like to cut things, put them back together. But that is not something that we came up with. This is the National Institute of Health Consensus Conference statement back in 1991. Experts from all over the world gathered together under one roof, and all of them, after reviewing all the data that was available to them, they came up unanimously with this statement, saying that only surgery works. 23 plus years later, we're still debating with the medical community as this, because a lot of people do not accept that really surgery is the only option for most of these patients. Today, not only the NIH endorses surgery as the most effective treatment against obesity, but all these other associations and societies, the American Medical Association, the Association of Family Practitioners, the National Heart, Lung, and Blood Institute, the International Diabetes Federation. They had a world symposium in Italy just a couple years ago, and they stated also unanimously that bariatric surgery is the most effective cure against diabetes. The ACS, IFSO, as well as the ASMBS, and very recently the American Heart Association endorses bariatric surgery as the most effective treatment for obesity. So let's talk about who qualifies for surgery at St. Luke's Hospital. We already said that you have to have a BMI of 40 or greater just to qualify by number alone. If it's between 35 and 40, you must have a comorbid condition. This is an insurance requirement, but you must have a history of attempted and failure to lose weight in the past. You have to demonstrate that. And we will teach you, once you come to our center, we will teach you how to do that. Patient must understand the risks, benefits, side effects, and rules of surgery. This is self-explanatory. If you don't know and understand the rules of this, maybe you shouldn't have the operation. And at least for now at St. Luke's, you have to be 18 years of age. We're not performing surgery in minors. Who does not qualify for surgery at St. Luke's? If you have an ongoing drug or alcohol abuse problem, then you do not qualify. You need an intervention, you need therapy, you need to be clean. If you have untreated or undertreated mental illnesses, psychosis, or personality disorders, or you suffer from bulimia nerves, if you have an eating disorder, then surgery is not going to help you. You need therapy. If you've had any mental health inpatient admission within the last 2 years, that's not going to necessarily disqualify you, but you have to demonstrate that you have been stable for at least 2 years with therapy before you are even considered to have an operation. On the other hand, if you have a diagnosis of a schizophrenia cluster, or a personality disorder, then you do not qualify for surgery. It is contraindicated. For women, if you're pregnant or you're planning to become pregnant within 2 years of surgery, we extremely recommend that you should wait. Wait after 2 years from surgery. The reason is that you're going to be losing a lot of weight very rapidly, and sometimes it's hard to keep up with the necessary nutrients to sustain a normal pregnancy. There's a higher risk associated with congenital malformations if you become pregnant within the first 2 years after surgery. That is why we strongly recommend not to get pregnant and to use some sort of contraceptive method to avoid pregnancy within the first 2 years. After this period of time, your pregnancy is going to be much better, much safer, much healthier. If you require a C-section, the operation will be much easier. You could have a completely normal, natural delivery. So just wait, and then you will have a better result. If you have mental or cognitive impairment that limits your ability to understand the procedure and thus precludes you signing a consent, well, then you shouldn't have the surgery. That's also self-explanatory. And last but not least, if your obesity is related to an endocrine disorder, a glandular problem, let's say that you haven't been seen by a primary care physician, and it happens to be that your thyroid is not working well, or your adrenal glands is just making too much steroids, well, then you do not need surgery. You're going to need therapy, and just medication or treatment will probably take care of your weight loss problem. So you need to be seen by your primary care. But if you come to our center, we're going to run labs as well, and we're more likely are going to be able to diagnose if this is the case or not. You should know that this surgery requires a great deal of commitment. Bariatric surgery is just a tool. It is the most powerful and the most effective tool out there, but it's just a tool. It's not going to work alone. You're going to have to diet. You're going to know what you eat, when you eat it, how you eat it. You must exercise. This has to be added to your daily routine. No excuses on this. You have to be very compliant and you have to follow up after surgery, taking your vitamins, doing your adjustments, etc. And you're gonna need a lot of support. Hopefully you'll have family that will support you. If you don't have anyone that is supportive, come to our meetings. We have an incredible network of remarkable individuals that will become your support. And we can help you in any way we can. If you do not do these things, you will fail. As I have mentioned before, there's a greater than 80% chance of you being successful after the surgery, but it's not a magic pill. It's not a sure fix. If you're not committed, if you're not compliant, if you do not follow up, you will fail. Let's review a little bit about your digestive system, and I'm gonna give you an idea of what we are gonna be doing after your surgery. This slide depicts a normal graphic or an illustration of what the GI system is. You can see the esophagus is connected to the stomach. That's where the food lands and essentially the digestion begins. After this, the food is going to pass into the small bowel, eventually will progress into the large bowel, and this happens several times during the day, and this is our normal digestive system. This is how we do the operations. There are 3 types of surgeries. These are the 3 more commonly performed procedures in the United States. 2 of them, the ones on the left, are restrictive. One is the gastric band, one is the sleeve gastrectomy. Both of them, as the description entails, are restrictive operations. They are designed to restrict the amount of food that you're gonna be able to eat. If you eat more than what you're supposed to, you're gonna become uncomfortable. You're gonna get nauseated. You might vomit. That's gonna deter you from eating too much, and that's how you lose weight. Unfortunately, the gastric band is very easy to cheat. If you have a sweet tooth, if you are big on eating your cake or chocolate or soda or ice cream, the band is not gonna do anything for you. Very unlikely to work because it's very easy to cheat. The sleeve gastrectomy, on the other hand, it also has a very strong metabolic component because we are eliminating a significant amount of cells that produce a hormone called ghrelin. The ghrelin hormone is the most powerful appetite stimulant that we know of, and we are removing that from your economy. And that is essentially gonna cause you to lose your appetite. So this is why this operation is the second best option, or the second most effective option, I may say. The depicted operation on the right, the Roux-en-Y gastric bypass, is by far the most effective surgery in the United States out of these 3. This is a combination of malabsorptive and restrictive. You're gonna have a very small stomach, about the size of a golf ball, and that's gonna be connected straight into a portion of your distal bowel. This way, you're gonna be able to eat only a small amount of food, and that food is gonna go straight into the bowel, and it's not gonna be digested until it reaches a point much more distally where it will meet the digestive enzymes, and this is where the digestion will begin. So again, if you can see it, it's a restrictive component because the stomach is very small. And it also has a malabsorptive component because you're not gonna be able to absorb the food well. You're gonna eat very little amounts and you're not gonna absorb it well. Hence the reason why this is the most effective surgery.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure.
Okay, let's talk about some of the possible complications that are associated with this surgery. All procedures can have, as a complication, clots to your lungs or your legs. This is one of the most common causes still today for deaths after surgery, and we take it very seriously. You're gonna be given a medication before your operation to make your blood thinner. And the most effective way to prevent clots in your legs and then from going into your lungs is to walk after the surgery. So as soon as you hit the floor after your operation, you're gonna be asked to move and walk. You're gonna have to be very active and do some laps around the nursing station. And this is again one of the most effective ways of preventing those clots from forming. There's always a chance of infection and bleeding. Bariatric patients are at a higher risk of developing infections as a result of their obesity. Our infection rate is among the lowest in the whole country, but there's always a chance of that. You will be given antibiotics before the surgery, and the operation is performed laparoscopically. So it's a completely different thing to have a small, tiny incision that gets infected as opposed to a big one if you would have your operation done open. So if you get an infection, it will be treated with antibiotics, sometimes needs to be open and drained, but it's not a big complication as opposed to an open surgery. Dehydration. You're not gonna be able to drink as much or as fast as you did before the surgery. So if you do not keep yourself well hydrated, well then you can run into problems of dehydration. We will teach you all those things and how to prevent that from happening. Any surgery, doesn't matter how big, how small, if it's done open or laparoscopically, there's always a chance of injury to other organs. Know that we have all the necessary equipment, state-of-the-art facilities, as well as the skills required to do these surgeries. So the chance of that happening is extremely small, but there's always a chance. If you do not take your vitamins and your supplements, there's always a chance also that you will develop vitamin and nutritional deficiencies. The best way to prevent that is take your supplements. Blockage of intestine. It doesn't matter the nature of the surgery that you ever had, if it was a uterus surgery or an appendix or a gallbladder, the way we heal is we create scar and adhesions inside our abdomen. Sometimes these adhesions will cause blockage of intestines. Sometimes, depending on the kind of surgery that you would choose, you could have an internal hernia. The importance of this is that if you're not feeling well, if you're having pain, if you're nauseated, if you're vomiting, you need to let us know. It could be something as easy as just to give you some fluids and allow your bowel to rest without any food for a couple of days, or it could be something that might require a surgical intervention. Either way, you just need to let us know and we will take care of it. Inherent to the gastric bypass or the sleeve, if you remember the animation that you just saw, there are staple lines involved with these surgeries, both with the bypass and the sleeve. So there's always a chance of a leak. This is one of the most dreaded complications after bariatric surgery. Our leak rate is extremely low, about 1/10 or 1/15 of the national average. And we are very proud of that. And I think the difference lies on the buttressing of our staple lines and our technique. So rest assured that before we close your abdomen after surgery, we will test this GI tract and make sure there's nothing leaking. And that's how we can produce this kind of results. Adjustable banding. There are certain complications related to the band that are not associated with the other operations and the other way around as well. If you have a band that is too tight and you're constantly vomiting or nauseated, you can have a band slippage, you can have an erosion, or you can have a leak. The next slide actually depicts these things. If you have a band and you're constantly eating more and more volume of food, you can dilate your pouch and that's going to be a problem. If you're constantly vomiting, you can have a slippage of your band. If the band is really tight and you're still not eating the way you're supposed to, you can develop an erosion. Statistically speaking, the band is the surgery that requires most revisions and most reoperations of all three of them. There's some studies that say that up to 30% of the time, these bands will need to have a reoperation. The experience in the United States with the band has been short of disappointing. It works only well for very few people. So if you're interested in this is the kind of surgery that we should have in the office, face to face. And again, if this is what you want to have done, well, we will discuss it in the office and eventually you are the one that decides which operation you want to have done. Let's talk about possible side effects, and let's start with the dumping syndrome. This is mostly related to the Roux-en-Y gastric bypass. If you remember the anatomy of the surgery, you're going to have a new small stomach that is going to be directly connected into the small bowel. If you eat something that is really sweet, something that has a high content of fat, something fried, or something that is just too concentrated, the bowel is not going to like that. It's going to try to dilute it, and it's going to steal some of that volume out of your vascular space. Hence, you're going to develop tachycardia, palpitations, crampy abdominal pain. You can have diarrhea, or you can feel, the sensation that you're fainting. I had some patients that have described the dumping syndrome as they thought that they were having a heart attack. It's a horrible sensation that actually is a good deterrent for you not eating those kind of foods. And that's why the gastric bypass is very effective. If you're not keeping up with your protein intake, you can suffer from temporary hair thinning. Of course, the treatment for that is just you have to take your protein and sometimes add some biotin to it. If you develop nausea or vomiting, let us know. This could be something as simple as just, again, giving your bowel some rest with IV fluids, or it could be the first sign or symptom of an obstruction, so you need to let us know. Most of the time, patients develop nausea or vomiting just simply by not eating the way they're supposed to, by taking too much of a bite or too big of it, or not chewing it well. We will talk and we will teach you about this when you come to the center. Changes in bowel habits goes back to the notion that you're not going to be able to drink as much as you did before. And one of the most common complications, or one of the most common complaints after surgery, is that people become constipated. We will also teach you how to prevent that. Last but not least, you're gonna have a lot of psychosocial implications. This is gonna be stressful. Whomever is ignorant to tell you that you're taking the easy way out, they just have no idea what our patients have to do in order to be successful. If we ask them unanimously, they will say that this was probably the best decision that they ever made, and the only regret they have is that they should have done it sooner. If you decide to have bariatric surgery with us, it will be truly our pleasure to welcome you to our program and to the family, and we will see you in the office. I'm gonna pass now to Maureen, that is gonna tell you everything you need to know about insurance and pre-certification. Thank you for joining us.
Let's talk about the pre-certification process to get to surgery. The first thing you want to make sure of is that you have the benefit for weight loss surgery. You should call the number on the back of your insurance card and ask them whether you have the benefit for weight loss surgery. You can look at the codes on this page and ask them for those specific numbers. You can't just go by the name of your insurance. I'm going to give an example. Some people have Capital Blue Cross and they work for company A. They might have the benefit for weight loss surgery. Another person might work for company B. They too have Capital Blue Cross, but they might not have the benefit for weight loss surgery. So it's really important that you find out for your particular plan. And then the other thing that has to go along with the benefit is you must meet the criteria. And as Dr. Claros had mentioned previously, you have to have that body mass index that's greater than 40 or be between 35 and 40 with medical conditions that are related to obesity. So what is it that our program requires? Our program does require what most insurances want to see. First, we require a dietary evaluation, a behavioral health evaluation. You must come to support group prior to being pre-certified. We'll need to have clearance from a cardiologist. You'll need to come in for an EGD, and it's possible that you might need a sleep study. We'll need to get a letter from your primary care physician, and if you use tobacco in any form, you will need to quit, and we will test you for that. Will your insurance company require more? They might. Some insurances require a 6-month or a 3-month process. Some insurances even require that you prove that you've been suffering with obesity for 2 or 5 years through documentation in a medical record. Now I know it sounds like a lot of things, but how are you going to know what to do? When you come into the office for the first time, you're going to sit down with multiple people, and one of them is going to be our pre-cert specialist. And she's going to give you a checklist that is made specific for you and your insurance company. So when you leave the office that day, you should know exactly what to do. When you come into the office for this first appointment, you should bring your calendar with you so that they can make some of these other consultation appointments for you. Sometimes they're able to get you in more quickly than if you try to make the appointments on your own. And now about finances. All out-of-pocket expense that needs to be paid to the hospital will have to be paid up front. Sometimes you may still get a bill from the surgeon's office. You may still get a bill from the anesthesiologist's office, and there still may be an outstanding balance to the hospital. We give it our best estimate as to what it is that you'll owe the hospital. So you should really find out from your insurance what is going to be your financial responsibility for an inpatient surgical stay. You might have a deductible, and that's usually an amount that comes right off the top. Say $100 or $500 deductible. You might have co-pays or co-insurance where you pay a particular percentage of the amount that is owed the hospital. Now I've seen this be 10%, 20%, I've seen it as high as 50%. So you could be talking about thousands of dollars. So that's why it's very important that you find out this amount ahead of time. It's very possible that you're covered 100%. As for an example, if you have Medicare and a Medicare supplement, you are covered 100%. So why should you come to St. Luke's Allentown to have your bariatric surgery? As Dr. Claros mentioned, we are a center of excellence through the ACS and the ASMBS, and that means that we went through a rigorous review from that organization. We have the equipment in the hospital to take care of those who are having weight loss surgery. All of our staff have been specially trained in the care of those having weight loss surgery. And we have the processes in place. Our surgeons' experience is a good reason to come to our facility. They are both board certified and they've both been formally trained in weight loss surgery, and they performed over 2,000 procedures. Our average length of stay is about 1.5 days, which means that most of you will go home the day after surgery. Sometimes we'll have patients who stay an extra day or so, and that usually is for inability to be able to keep sipping well enough. They might have a little bit of nausea, or maybe the pain isn't controlled well enough with medicine that you take by mouth. We need to make sure that you're sipping well and that the pain medicine that you're taking in pill form is working for you. Many of you ask, when do I get to go back to work? And we usually say 2 to 3 weeks is a good amount of time. Now, there are some patients who have gone back earlier, but we really don't suggest it. You need to give yourself some time to recover from surgery and to get used to your new way of eating and drinking, and that does take some time. So again, I want to say you should take off 2 to 3 weeks. We do have a very experienced multidisciplinary team here at St. Luke's. Many of us have been working in bariatrics for many years. And several members of our team have actually had weight loss surgery. So you get that lived experience of somebody who had it, that you can ask how it is that they've been able to remain so successful for such a long period of time. In 2010, we did win an achievement award in operational excellence, and that was from the Hospital Association of Pennsylvania, and that was for our Bariatric Patient Access Improvement Project. We have that small hospital feel here at Allentown, but yet we have the benefit of being part of a very successful 6-hospital network. All of our psych evaluations and dietary evaluations are done at one time, and we don't have a program fee. I know there are some other centers in the area that do charge a program fee, but we don't have such a fee. And now I'm going to turn things over to our bariatric coordinator, Terry Davis.
Hi, I'm Terry Davis. I'm the bariatric program coordinator at St. Luke's Allentown. Before I share some of our amazing results, let me ask you a few questions. How would you like to be able to bend over and tie your shoes, or tuck your shirt in your pants? Or how about ride an amusement park ride, or fit in a stadium seat? Have you dieted in the past only to regain more weight than what you lost? And wouldn't it be great to get rid of some or all of your medications for things like diabetes or hypertension? If you decide to have bariatric surgery, you will tie your shoes, wear your shirt tucked in, fit in regular seating, and the yo-yo dieting will end. But more importantly, you will become a healthier individual with improvement or even resolution in your medical conditions. I had bariatric surgery in May of 2004 and lost 147 pounds. Prior to surgery, I was taking multiple medications for high blood pressure. I was borderline diabetic with fluctuating blood glucose levels and was on the verge of a knee replacement. I had barely enough energy to get through a shift of work. Bariatric surgery has changed all of that for me. I'm off blood pressure medicine, my blood sugar is normal, and my knees no longer hurt. My life has totally changed. I'm sure surgery is not your first choice to lose weight. You probably have been thinking about it for a while. It's also not easy. We operate on your stomach and not your mind, and sometimes the mind is the most difficult to overcome. But the entire team is here to support you and encourage you. Your success is our success. So let me share some of our amazing transformations. First, meet Larry. Larry pursued bariatric surgery for several reasons. He had severe sleep apnea, abnormal blood sugars, high blood pressure, and an irregular heartbeat. He also had a very physical job but found himself unable to fulfill his duties at work. And when Larry was no longer able to get on the floor and play with his young daughter, he decided that enough was enough. Since surgery, his medical problems have all resolved. He runs circles around his coworkers, and the most rewarding thing that has happened is he's now able to be the father he always wanted to be. Next, we have Lourdes. Lourdes loves to dance. She likes to salsa and tango, but the pain in her knees and her shortness of breath kept her off the dance floor. Lourdes not only found it difficult to dance, she couldn't walk very long distances or go up many steps. Sleeping wasn't easy either, as she also suffered with sleep apnea and needed to wear CPAP at night. After her sleeve gastrectomy, Lourdes feels like a new woman. She has more energy, her knees no longer hurt. She loves taking walks, but what she loves most is lighting up the dance floor with her husband. For Marianne, the decision to have surgery was not only about health, it was about confidence and self-esteem. Marianne suffered with diabetes and high blood pressure. And as a single woman, she lacked the ability to feel comfortable dating and developing relationships. Since surgery, she has not only lost weight, she lost her medications and a tremendous amount of fear and self-doubt. And in her words, she states that she's gained energy, self-confidence, her health, her future, her sparkle, and the freedom to be the real Marianne. Last, but certainly not least, is Deb. Prior to surgery, Deb's obesity had not yet taken a toll on her body. She did not have any medical problems. Her problem was obesity. As a grade school teacher, she found it difficult to keep up with the children. She would be tired at the end of her day and had little energy to be the wife and mother she needed to be when she arrived home. She confessed that when her son was an infant, she missed out on some of the bonding a mother does with a newborn because she wasn't able to hold him for long periods of time because of back pain and mere exhaustion. In fact, Deb was afraid that one day she just wouldn't wake up due to her obesity. After surgery, Deb no longer has any fears. She has embraced her new lifestyle. She is healthy and happy and is able to care for her family the way she has always wanted to. In fact, she hopes to be able to add to her family in the very near future and experience the joys of motherhood she previously missed out on.